Hello, everybody, and welcome to the American College of Cardiology Prevention Section meeting, where we're going to be talking today about cardiometabolic syndrome. So today's speakers we have as my name is Dr. John Baker. I am the co-chair of the cardiovascular contingency, cardiovascular care team, and the cardiovascular prevention section, along with Nathan Wong, who we'll introduce in a moment. Um, in your chat section, we will have the essentially where you basically you're going to have your questions. So the chat section will have separate. So you look at the bottom of your thing, that will be your chat. Q&A was where you'd like to ask all questions. So all your questions ask in the Q&A section instead of instead of the way that you ordinarily do it. So put it in the Q&A section. And then we'll answer them at the second point. So without further ado, again, I'm Dr. John Baker. I'm an invasive interventional cardiologist at Anaheim Regional Medical Center. I am the current treasurer of the California ACC. And I'd like to first introduce Dr. Wenjun Fan. Dr. Fan is an associate professor in the Department of Epidemiology and Biostatistics at the University of California. Um, she has got a joint appointment with the Division of Cardiology. She holds a PhD in public health with focus in disease prevention, and also with a focus in dyslipidemia. She has the clinical effectiveness of cardiometabolic therapy. She's authored over 50 peer-reviewed articles and serves as an associate editor for the cardiovascular diabetology and cardiovascular endocrinology and metabolism section. Dr. Fan is an award-winning educator teaching associate graduate level epidemiologic methods and data analysis courses. She actively mentors medical students, MPH, doctoral, and undergraduate students, contribute to curriculum vitae. Dr. Wong is also the co-chair of the California Prevention Section. He specialized in preventive cardiology at the University of California Irvine Medical Center. He has joint appointments with epidemiology with UC Irvine and UCLA Population Health. He holds an MPH and a PhD in epidemiology from Yale University and is a fellow of the American College of Cardiology, past president of the ASPC and the Pacific Lipid Association. He's authored about 500 manuscripts, including 8 textbooks of preventive cardiology, including preventive cardiology as a companion to Braunwald heart disease. He's serving as an editor-in-chief in the Preventive Cardiology, Journal of Preventive Cardiology, as well as editor-in-chief for the Journal of Clinical Medicine. So without further ado, I'd like to introduce Dr. Wenjun Fan, who's going to start us off in talking about the metabolic syndrome. So metabolic syndrome is a great hot topic. So without any further ado, Dr. Fan.
Thank you so much, Dr. Baker, for the introduction. Hi, everyone. It's a great honor to be here and talk about this new concept of cardiovascular kidney and metabolic syndrome. I'm going to go ahead and share my slides. Can you see my slides here?
Yes.
Okay, wonderful. So yeah, as Dr. Baker just introduced, I serve on different committees at the AHA. One of the group that I joined is the Heart Disease and Stroke Statistics Report. And one of the major updates for next year's report is that we updated the chapter Metabolic Syndrome to CKM syndrome. So we kind of want to replace the dated concept with this most recent updated concept. So we're going to spend the time today talking about the epidemiology and then also the clinical management of the CKM syndrome. So as you can tell from the name, it's a conceptual frameworks that include individuals both at risk for cardiovascular disease or already have existing cardiovascular disease. So it will divide the group of people into different stages. And then the increased likelihood of the CKM syndrome and its adverse outcomes is further influenced by many different factors. Later, we will have a slide showing factors from individual level all the way to social factors level. But let's first just take a look at how the CKM syndrome was defined. So this concept was first proposed in the 2023 AHA scientific session in November, and then this paper got published early 2024 last year. So it's a very new concept. We're still in the exploratory stage of this disease. So first, they divide the syndromes into 5 different stages. Starting from the left, people at stage 0 are free of any of the risk factors mentioned on this graph here. So the whole of the goal for this stage is to maintain or preserve the cardiovascular health. One of the recommendation is to follow the Life Essential 8 matrix. It is an updated version from Life Simple 7, further adding sleep health as one of the factors. So if the individual have some risk factors, specifically excessive or dysfunctional adipose tissues, measured by overweight, obesity, especially abdominal obesity, or they have impaired glucose tolerance, they will move on to stage 1. So they kind of define it in a hierarchical way. So if you have some additional risk factors or conditions, you will move on to the next stage. So stage 1 is pretty much just focused on overweight, obesity, or pre-diabetes. If you have additional risk factors, particularly metabolic risk factors, either you have metabolic syndrome, hypertension, hypertriglyceridemia, or type 2 diabetes, or moderate to high risk for chronic kidney disease, you will move on to the stage 2. Later, you will see this is actually the most prevalent stage on the population level. Um, moving on, if you further develop some subclinical CVD, for example, subclinical ASCVD measured by coronary artery calcification, or you have subclinical heart failure measured by cardiac biomarkers or imagings, you will move on to stage 3. And then also, if those imaging data or measurement is not available, there are risk equivalents of subclinical CVD as very high risk CKD, or we will introduce later a risk calculator, PREVENT. So if you have a PREVENT score over 20%, you'll be qualified as a stage 3 CKM. At the last stage, if you develop clinical CVD, including coronary heart disease, heart failure, peripheral artery disease, stroke, or AFib, you will move on to the last stage, stage 4. So that's a typical, like a clinical CVD. So this diagram here show how we define the 5 stages of this syndrome. I know everyone is an expert on this, the underlying like pathological pathway connecting different conditions. I'm just gonna briefly describe the graphs here. So this image displays the pathophysiology underlying the CKM syndrome. So it's most commonly originated from the excessive adipose tissues or dysfunctional adipose tissues or both. And there are, as you can tell, multiple pathological processes related to the dysfunctional adipose tissue then results in insulin resistance and eventually hyperglycemia. As you can see in the center, the inflammation, oxidative stress, insulin resistance, vascular dysfunction, they are highlighted as a central process leading to the development of the metabolic risk factors or to the progression of kidney disease. And then it has the potential to like heart and kidney interactions and to eventually the development of the cardiovascular disease. So metabolic risk factors and chronic kidney disease further predisposed to cardiovascular disease through multiple direct or indirect pathways shown on this graph. As I said, this is a relatively new concept. We are still exploring this syndrome, but here are the current scientific understanding of this disease. So we realize that the CKM syndrome results in excessive morbidity and mortality beyond the sum of each individual part. So there must be some interaction in between that amplify the impact or the risk for the adverse outcome. And then also the metabolic risk factors cause end organ damage in multiple systems, including the heart, the kidney, and vasculator. And then the last one is the basic mechanism of the end organ injury are hemodynamic, metabolic, inflammatory, and fibrotic. So there are different pathological processes. Here is the social ecological framework. For all the factors we have introduced so far is limited within the individual level. So there are individual predisposition factors like lifestyles or like psychological stress that might make this individual more sensitive to have CKM syndrome. And beyond the individual level, there are some behavior factors, for example, like smoking or poor sleep quality, unhealthy dietary pattern, or lack of physical activity will put another layer of higher risk for CKM. And beyond the behavior, we have the relationship among other individuals, like whether you have support or any impact from the neighbors, the peers, your friends, and family. Moving up to a community level, there are also risk factors from an environment perspective, either the chemical exposure or your neighborhood or your built environment or workplace. There are also some structural factors involved on this level. And then the last layer or the ultimate umbrella up there is the social factors. So eventually it's going to impact it by the economy, education level, social needs, and then also our healthcare delivery system. So this is really a multi-level or multi-layer framework to actually define their risk for CKM. This is just a brief summary. That graph have a lot of information, but for clinical use, this is a simple version of the 5 staging system. So if they are free of any of the risk factors mentioned, they will be on stage 0. Only pre-diabetes or obesity, then they will be at stage 1. If they further have metabolic risk factors or CKD, stage 2, subclinical CVD, or have a high prevent or estimated CVD risk over 20%, stage 3. And if they have any clinical presentations for CVD, they will move on to stage 4. Just so you know, stage 4 has 2 subgroups. 4A is further with kidney failure, and 4B is CVD without kidney failure. Now, I'm going to talk a little bit about the epidemiology of the CKM syndrome in the United States. So here is a paper using the National Health and Nutrition Examination Surveys, which is a population level survey conducted every other year. So this study assembled the data for the past 2 decades, 20 years, to see what would be the trends for the prevalence of each stage on a population level. So if you combine the 20 years data, the overall prevalence for each stage is displayed on this graph. I'm just going to highlight some of the key findings. When we look at the healthy stage, only 10% of the adult population are actually in this stage, which means they're free of metabolic risk factors. This percentage is very low. As you can imagine, only 1 in 10 individuals will be in the healthy stage. And then about a quarter of the individuals only have obesity or prediabetes. That's 1/4. That's a high percentage as well. If you look at the blue dot on this graph, that's the stage two. That's the prevalence for stage two is almost half of the population. We're actually at this stage. And the last one, the red color is a stage four, which is they have clinical CBD, is marked as the orange color here. It's roughly around 9%. So if you look at the trends over the past 20 years, they remain relatively stable. So there's no statistically significant change over time. We further stratify by sex. So the graph to the left is for females and graph to the right is for males. The color represent different stages of CKM, with the green indicate the healthy stage and the dark red color represent the advanced stage of stage four. So if you look at the females, like almost 30 years ago, we still have close to 1/3 of the females were at a healthy stage. But more recently, this percentage decreased to only 15%, almost half of the number. Whereas more and more people are moving into the stage two CKM. So it grows from like 30% all the way to close to 40%. If you look at the males to the right, I would say in general, females are doing a better job than males. As you can see, males have only about 16% back to early 90s. And then right now, it also decreased in half, only 8%. We're at the healthy or the green color, the stage zero, where the majority moves to either stage two or like stage three here. The clinical CBD is kind of relatively stable over time for both groups. Now let's move on to other factors beyond clinical risk factors. So remember from the socioeconomic frameworks, there are social determinant of health factors that will also have some impact on the prevalence of each stage. So here is a study, I believe also use the enhanced study, but to the right, to the left, you'll see they stratify by different social determinant of health factors. The first one is like education, employment status, family income to poverty ratio, insurance, regular access to care or home ownership. And then the bar represent the percentage of each stage, with the green one represent stage zero, the dark red one represent the advanced stage of 3 and 4. So the first finding is that the first row is like less than high school education, whereas the last row is college or higher degree. So you see the CKM stage four was more prevalent among individuals with lower education level. The red bar, it's greater compared to the red bar at the bottom. And then we have observed similar patterns and then suggest that maybe unemployed, experiencing economic instability will be associated with higher percentage of advanced CKM stage. Same thing here. And then when we look at the left part, so when we look at prevalence of stage zero, they are more prevalent among people with advanced social determinants of health, like higher education level, employed, or higher income level, same as bottom. So social factors do play in the staging, the prevalence of the staging, CKM staging. Now, the last piece for the EP studies is we want to explore the association between different CKM stages with mortality as the outcome. So the top graph still shows the prevalence of each stage among females and males. So this is the same data as shown in the previous slides. But on the bottom, it is the hazard ratio for all-cause mortality. And we use the stage 0 as the reference group. So you see the hazard ratio is equal to 1. So you can look at for females, even at the stage 1, there's a slightly increased risk for all-cause mortality compared to stage 0. With the increase of the staging, maybe all the way to stage 4, there are more than triple the risk of all-cause mortality in women compared to in women at stage 4 compared to women at stage 0. I would say men has a similar pattern, but the magnitude is not that profound as women. We are currently working on another projects looking at postmenopausal women specifically. And we found that postmenopausal women, even they're at stage 0 or very early stage, they have equivalent risk for CVD mortality compared to men at the same age. All right, so if you remember in the stage 3, if all the imaging measurement is not feasible, you can use another risk calculator called Prevent Score to estimate a person's CVD risk. So that could be a substitute measurement to classify stage 3. So Prevent equation could estimate both absolute 10 years or 30 years risk for three outcomes: total CVD, prevent CVD, ASCVD specifically, or like heart failure. So those are three separate calculator. This equation is derived from and validated using the data from over 6.5 million US adults across multiple data sets. And this here is very important. This is only applicable for adults age 30 to 79 without prior CVD. So this is for primary prevention purpose, and they have to fit into this age range. And they do offer three optional predictors, which is UACR, hemoglobin A1C, and then social deprivation index measured by the zip code. So these three factors will further personalize the risk and get you a more precise estimate. So just you know, prevent is replacing the previous risk calculator, pool cohorts equation. Some of the outstanding feature is that prevent is a race-free calculator, whereas the PCE, you have to specify your risk category. And it also provides a more precise absolute risk assessment, which often results in downgrading the risk status for individuals previously being classified as high risk for PCE. So just a little bit comparison between the two calculators. I put a link here. I can show you real quick. If you just search for prevent, it will pump up a window looks like this. As a clinician, if you have a patient, you can just type in their values for each factors here, and then click calculate. It will pump up one risk score for 10-year risk and the other one for 30 years. And you can choose either CVD, ASCVD, or heart failure. They will pump up different results. And let me give you an example. So I have a female patient, age 48, has a total cholesterol of 200 milligram per deciliter, HDL 60, SBP 140, BMI 30, EGFR 95, and have diabetes, currently smoker, not on medication for hypertension, and due on medications for lipid lowering purpose. So if I choose ASCVD, this will be the calculated risk factor for 10 year and the other one for 30 year. If I click on heart failure, this will be the two results. Because those three models were built separately, so you can see the sum of ASCVD and heart failure exit the total CVD risk score. So it's not a good practice to just add up this two number. But if you want to know the total CVD risk, you should choose this calculator, this outcome specifically. And yeah, and just another note, if this number is greater than 20%, I mean the 10-year risk is greater than 20%, then this patients will be classified as a stage 3 CKM. Um, so that's the introduction of the CKM, but how about the clinical application of this framework? First, it can help the clinician to screen for CKM risk factors for your patients. As I mentioned, there's a Life Essential 8 matrix. Those are the 8 risk factors that you should talk about with your patients, and also consider the three additional risk factors. The two of them are clinically indicated, like A1C or kidney function. And then the next one is to move on, assess CVD risk. Whether you need to either calculate it, personalize it, or reclassify to a different group. And then the next one is sometimes the medical term for different diseases hard to communicate with the patients. But if you put into a framework and say, okay, you are already on advanced stage of CKM, you're at a high risk for mortality, especially for CVD mortality, then it will be easier communications with the patients. And then the last one, we always try to promote the concept of cardiovascular health instead of cardiovascular disease treatments, like treating disease. We try to maintain at a healthy stage. Um, I put a reference at the bottom, so there is a available algorithms for the management of the patients with CKM syndrome, range from stage 1 all the way to stage 3. I believe there will be another documents that serve as a guideline for the like suggested treatments for different stages. So this is more like early documentations for that. So you will see for stage 1, there's a emphasis on weight loss and also the prevent the progression to diabetes from pre-diabetes. And then for stage 2, depending on the condition the patients have, you will need to address either the hypertriglyceridemia, hypertension, or kidney disease, or with the diabetes from lifestyle to all the medications. So just if the patients have A1C over 7.5, it would be good to co-utilize metformin and other novel medications that show cardiovascular benefits. But if their A1C is in a relatively low level, you can probably skip metformin and prescribe the cardioprotective agents directly. Yeah, this is just suggestions to control for stage 3 patients with subclinical CVD. Um, there are a lot of opportunities for prevention and management of the CKM. Many of the aspects I've already covered, but the last two, those are the new agents that show cardiovascular benefits. So maybe we can take advantage that in properly managing patients at the corresponding stages. All right, here's my last slide. As you can tell, this is really incorporating a different condition into one framework. So in terms of the care delivery is interdisciplinary care approach rather than a single specialty. And also, if you look at the data stratified by age group, even at a very young adulthood, like 18 to 44 years old, the percentage of stage 0 or the healthy stage is only 18%, and close to 40% of those young adults are already at stage 2. That's a very striking number. So we should emphasize the early life prevention rather than late life. Strategies to support weight loss, that's everything probably oriented from the obesity issue. So weight loss could be a fundamental approach. And then the last one is the management of CVD in patients, further with CKD. So there's like a multiple condition composite control approach. Lastly, the patients is the center. So it's a patient-centered implementation focus. You should communicate all those framework with your patients to either we maintain in a relatively early stage, or we should figure out a way to prevent the progression to a more advanced stage. That'll be all from me. Thank you so much.
Outstanding. Thank you, Dr. Fan. That was a wonderful presentation. So thank you very much. Now we're going to be moving to Dr. Wong's presentation. So Dr. Wong, and also just to make sure that when you have a question, feel free to put it in the Q&A. Q&A is at the bottom of your screen. So if you're using a mobile phone, you may have to tap a little white button at the top of the screen. It's a white square. But feel free to put your questions in the chat. We'll be able to, I'm sorry, in the Q&A, and we'll be able to answer those at the end. Dr. Wong.
Okay, well, thank you very much, John, and also thank you, Wenjin, for giving such a superb background on CKM. So my job is to really try to go through in the remaining time. I'll have to talk pretty fast, some of the key management strategies, both lifestyle and pharmacologic, to help prevent the progression of CKM and its and and its consequences. So, the American Heart Association nicely has laid out their Life's Essential Eight, right? So, this is trying to optimize health behaviors, namely diet, physical activity, preventing nicotine exposure, and optimal sleep, which they define as 7 to 9 hours a night. So that's hard for many of us to get, but we should strive for it. In health factors, we're going to talk about their management a bit, body mass index, blood lipids, glucose, and blood pressure. And the Life's Essential Eight document comes up with these categories where, depending on what level you are for each of these, you get a certain number of points, and you can kind of average those points across these eight factors, and you can come up with a cumulative kind of cardiovascular health score. And we know that if you have multiple health factors and health behaviors at ideal levels, you can see here that if most or all of them are at ideal levels, your risk of developing cardiovascular disease is up to 90% lower. So very dramatic effects, and this is kind of the whole premise for preventing progression of these cardiometabolic syndrome, cardio kidney metabolic syndrome stages that Dr. Fan talked about. Now, in people with diabetes, we know from these and other studies, these studies Dr. Fan worked on and authored with me the last several years. We're doing a modest job at individual risk factors, but the problem is if we look at multiple risk factors such as A1C, blood pressure, and LDL, fewer than 20% are at target, and it's fewer than 10% if you add non-smoking status and body mass index, right? So our cardiometabolic patients need to understand, right? And our diabetes patients need to understand that their disease is much more than blood sugar, but it's making sure that all these factors are optimized to prevent further progression of their disease and adverse cardiovascular outcomes. We know from prospective studies, such as this pooling of three cohorts we did about 10 years ago, that if you're at target for all three of these factors, LDL, blood pressure, and A1C, your risk future cardiovascular events are as much as about 60% lower. So this amazing potential for prevention of adverse outcomes if you control these factors. And the Steno-2 clinical trial still remains one of the few, and it's a fairly small trial done in Europe with only about 160 people with diabetes, showing that if you intensively manage these multiple risk factors, as shown on the left, that your risk of future adverse cardiovascular outcomes is over 50% lower. So it really kind of parallels our observational data that I just showed you. So remember that a healthy diet is really based on a DASH Mediterranean type dietary pattern, emphasizing intake of vegetables, fruits, whole grains, replacing saturated fat with mono and polyunsaturated fats, and really restricting sodium intake, and really trying to prevent avoid intake of trans fats, right? And really trying to minimize intake, particularly of processed meats and sugar sweetened beverages and refined carbohydrates. We know from the diabetes prevention program that people that followed an intensive lifestyle had an even greater effect in preventing diabetes, a 58% risk reduction than even metformin, which offered a 31% risk reduction for development of diabetes. And certainly the Mediterranean diet has nicely been shown to prevent adverse cardiovascular outcomes, as shown by the PREDIMED study, also done in Europe, showing roughly a 30% reduction in risk if you follow a Mediterranean diet, either supplemented by nuts or extra virgin olive oil. Physical activity focuses on 150 minutes of moderate or 75 minutes of vigorous intensity physical activity per week, along with strength training, and at least do some minimal activity, right? So the greatest benefit is this doing some rather than being a couch potato, but ideally the levels that I recommended. And we know there's a wealth of data from observational studies and clinical trials that show that adverse cardiovascular outcomes are prevented by regular physical activity, such as shown here in the Women's Health Initiative study. Our guidelines have taken different risk categories, which will likely be revised based on the prevent risk score that Dr. Fan nicely described. And we have some inkling of what this might be. So like and I'll show you this in a minute regarding antihypertensive therapy. But the premise has been we treat prevention is really risk-based rather than numbers-based. So when I first got into this field 35 years ago, we would treat patients for cholesterol according to their LDL cholesterol levels. But now it's based on risk, with treatment definitely recommended if you're in that high risk category. And then if you're in the borderline risk category, really considering this long list of risk enhancing factors, which I don't have time to discuss. And if you're still uncertain, you can consider coronary calcium, right? So in this paper I co-authored with David Marin and others last year, we also felt that coronary calcium can be more actionable if you stage disease, right? So stage 0 through 4, if you have a very high calcium score, like 1,000 or higher, that's stage 4. And if you're 300 or higher, we really want to see that LDL cholesterol below 55 milligram per deciliter. So this is all part of the CKM workup that Dr. Fan mentioned. And if you have significant subclinical disease, you're already in stage 3 CKM. We also know in patients with diabetes and metabolic syndrome that coronary calcium can be a very effective risk stratifier. In this paper that Shaista Malik and I worked on when she was a cardiology fellow here at UCI years ago, She now directs our integrative medicine enterprise. And you can see here that, if you have a 0 calcium score, even if you have metabolic syndrome or diabetes, your risk is quite low, right? But it rises in a graded fashion with higher levels of coronary calcium. So in terms of risk factor management strategies, when we're talking about lipids, the ADA standards of care updated in 2024 really has some of the latest recommendations. So for primary prevention people with diabetes without ASCVD, really to try to get that LDL below 70. And if it's above that on a despite a high intensity statin or most highly or most tolerated dose, consider ezetimibe or a PCSK9 inhibitor. And there are of course newer evidence-based therapies proven to reduce risk, such as bempedoic acid, that can be considered in secondary prevention. So when you have both diabetes and ASCVD, remember that's a very high risk condition. So we really want to see that LDL cholesterol below 55, and if it's above that, to consider a non-statin therapy. As we know, non-statin therapies are terribly underutilized. Even ezetimibe, generic and out for many years. Very few people are actually using that. So this is very important. We know statins have a similar effect on reducing major vascular events, both in people with and without diabetes. 21% risk per millimole, which is reduction. That's about 40 milligram per deciliter. And we also know that data from the Fourier study, for example, involving the PCSK9 inhibitor evolocumab, shows, a similar relative risk reduction. But remember, patients with diabetes are much higher absolute risks, right? So the number needed to treat is more favorable. We also, of course, have now inclisiran, right? So this is a double-stranded siRNA that prevents the production of PCSK9, and from injections at baseline 3 months and every 6 months later, you get about a 50% reduction in LDL. So this is also an option if the patient has difficulty getting a PCSK9, although I learned yesterday that I believe it's Express Scripts is going to bring down the price of a PCSK9 to much lower levels, less than half of what it currently is. So it's going to be much less expensive moving forward. We know that particularly people with CKM are more likely to have elevated triglycerides, and these individuals have excess residual risk from ASCVD. But very little has been shown to really improve cardiovascular outcomes, and our trials involving fibrates and niacin have largely failed. Really, only pure EPA fish oil, icosapent ethyl, has been shown to have benefit in the REDUCE IT trial in people with established CVD or diabetes and multiple risk factors. Here you see a 25% risk reduction with an astounding number needed to treat of 21. So this really is an important therapy for reducing that residual risk in many patients with CKM, and guidelines from around the world recommend its use in people with moderately elevated triglycerides, with diabetes or CKD. I can't give a talk without at least mentioning one of my favorite topics, Lp(a), in this paper that Dr. Fan and I published last year in JACC. We show that, and relevant to the discussion today, that Lp(a) was a much stronger predictor of incident events in people with diabetes compared to those without diabetes. And we know now, of course, that the National Lipid Association recommends universal testing a level of 50 milligram per deciliter or about 100 nanomoles per liter or higher warrants intensive further risk reduction efforts. And we have therapies in development. Hopefully, the first will show cardiovascular benefit next year. So we'll hopefully have another discussion on Lp(a) next year in this series. Blood pressure control, right? Initially shown by UKPDS, tighter blood pressure control dramatically reduces both micro and macrovascular complications. The SPRINT trial, while not done in people with diabetes, showed a 25% risk reduction, but there are data applying SPRINT eligibility criteria to ACCORD patients that does seem to suggest a benefit. But and unfortunately, ACCORD in people with diabetes did not show more intensive blood pressure control to improve outcomes. But as I mentioned, they did a post hoc analysis using similar SPRINT patients from this trial, which did show a improvement. And we also have more recent trials that are further getting people to think, should we really have a target even lower, like less than 120? And we now have data from the BP Road study in people with diabetes showing a convincing benefit from more intensive blood pressure control. Very interesting are the new 2025 hypertension guidelines. That would be a great topic for another webinar. And here they actually do use the prevent risk score. And if you are 7.5% or greater, then you should be initiating, or if you have CKD or diabetes, you should be initiating antihypertensive therapy at a blood pressure of 130/80 or higher. So this used to be 10%, if you recall, in the 2018 guidelines. So it suggests that prevent is going to maybe be using somewhat lower thresholds to recommend similar levels of intervention as prior guidelines did. So this slide, okay, I guess it's coming out okay, but this is the only slide I have on aspirin, just showing that, the more recent data like the ASCEND trial really shows the bleed-in risk largely to counterbalance that cardiovascular benefits, to the point that you're not really getting much net clinical benefit even in higher risk patients with diabetes. So this is quite a debate. Certainly aspirin is still recommended in secondary prevention, but we've kind of backed off on its use in primary prevention people. So Dr. Amin Sabet next month is going to devote a whole session on talking about inflammation. This is the only slide I have on it, right? We now have low dose colchicine shown by several trials that can be used to further reduce residual risk. We don't really have evidence. No, down here there was a 35% lower risk found in a subgroup with diabetes. So there is some presumed benefit also in people with CKM and specifically diabetes from low-dose colchicine. The last few minutes, and I won't have enough time to devote justice to this topic, right? But the newer, very exciting therapies that really first came on our radar screen 10 years ago when at ESC the first SGLT2 trial, EMFA-REG, was reported out. And since then, there's been a wealth of data showing that both of these really prevent cardiovascular events, SGLT2 inhibitors to a greater extent, heart failure. They're now part of the pillars of heart failure care, and both also seem to have benefits for preventing progression of kidney disease, and GLP-1 receptor agonists, of course, have weight reduction benefits. And And we have different guidelines, and they mainly say that independent of glucose control, we should be given these therapies because of their cardiovascular benefits. So this is key to understand, right? That we're not just given these if your A1C is still elevated, but you're given them as cardiovascular risk reducing agents, right? So this is really critical. And InfraReg, of course, started this whole cascade of studies 10 years ago when it was released and showed dramatic benefits, particularly for cardiovascular death, even all-cause mortality, and heart failure hospitalization. So this really then spurned a whole wealth of trials, and the rest is kind of history, right? And we have meta-analyses showing the benefits from the GLP-1 receptor agonists. And I'll just briefly mention Sustain 6, right? Semaglutide and diabetes showing a 24% reduction in composite outcome, 39% reduction in stroke. We're almost finished here. And of course, the weight reduction benefits, critical for people with CKM, and semaglutide, of course, got a lot of great press with its 15% weight reduction. And we've even projected that we could, if the eligible U.S. adult population were given semaglutide, we might have 43 million fewer people with obesity, and prevent 1.5 million cardiovascular events over 10 years. The SELECT trial was the first of the GLP-1 receptor agonist trials, in this case in people with established CVD, to demonstrate superiority for prevention of cardiovascular outcomes. So these now have the evidence base to reduce cardiovascular outcomes, and our cardiology community needs to embrace them as cardiovascular drugs and not just think of them as something the diabetologist or the primary care physician should be responsible for. And even prevention of diabetes. Look at the top line there, a um, a 73% reduction in time to develop in diabetes based on an A1C of 6.5, and multiple effects on other risk factors. And we've also shown if you give the US eligible population based on select semaglutide, we could maybe prevent almost 100,000 cases of diabetes annually and almost 17,000 cardiovascular events. Um, but you have to stay on these drugs, right? If you go off them, as step 4 showed us, your weight will revert. You'll gain weight, and some studies show you might even gain more weight if you go off these therapies. And lastly, very exciting are these combinations, the GIP, GLPs, like tirzepatide, showing an astounding 20% or more weight reduction. Very exciting. And there's even their first outcomes trial compared to dulaglutide and older GLP showed non-inferiority, and did show in all-cause mortality benefit. And some real world data on the right shows dramatic lower outcomes, cardiovascular outcomes for tirzepatide compared to GLP-1s. SURMOUNT is, of course, ongoing. We're one of the sites at UC Irvine, led by Dr. Andy Lee, and this is going to be important to try to demonstrate superiority compared to placebo in people with overweight or obesity without diabetes. So the last slide here is just to remind us we need this cardiometabolic care team, right? That encompasses lifestyle interventionalists and the cardiologists and the diabetologists, together with primary care providers, pharmacists, and nurses and nurse practitioners. So with that, this is the conclusion. We talked about how multiple risk factor control is very poor, but if we do control multiple risk factors in the setting of CKM and diabetes specifically, we can reduce cardiovascular outcomes by over 50%. Cardiologists and other clinicians really need to embrace these newer therapies. I think certainly SGLT2s are there for heart failure, so they're used to that. But the GLP-1s, right? We really need to embrace them in the cardiology community. And then, of course, there are more and more benefits seen from these, ranging from Alzheimer's disease to sleep apnea, and of course, cardiovascular outcomes. The data keeps accumulating. So, with that, thank you for your attention. Hopefully, we have a few minutes for discussion here.
We do. Thank you, Dr. Wall. That was terrific. And thank you, Dr. Fan. That was terrific. So again, if you have questions, put them in the Q&A and we'll get to them. I have a question actually for both of you. So, Dr. Fan, I wanted to emphasize something that you said in your presentation is that when you have cardiometabolic syndrome, your mortality is more than the sum of its parts, meaning that if you have diabetes plus something else, that if your mortality is higher than that of the diabetes alone. We know with kidney disease, chronic kidney disease, there are stages where you have stage 1 through 4. We know the mortality dramatically changes as you go from stage 1 to stage 5. And I'm wondering, for the both of you, do you have those statistics of what the mortality ranges are when you go from stage 1 to stage 4 chronic cardiometabolic syndrome? And then secondly, I know the PREVENT trial is very good at detecting where you are in the stages. If you decrease someone from stage 3 to stage 2 or stage 4 to stage 3, how do you affect their mortality? So whoever wants to go first.
I'll let Dr. Fan take it on. That's her specialty.
Great.
No, we are, as I mentioned, we just launched like two projects that exactly answer your question. So first is the one that among the postmenopausal women, right? So we want to see the mortality rate across different stages. Of course, with increased staging, the mortality rates, especially CVD mortality rate, will increase dramatically. And then for the other questions, we have another graduate students looking at the trajectory of different stagings after like 5 or 10 years observations among community-based cohorts and see how that would further affect the CVD mortality. So we used the group of people either remain stable or regress to a previous stage as a reference group, and then people progress to a more advanced stages definitely had a higher risk of CVD mortality in our study. We just want to quantify that across different subgroups, either like males and females or like according to different social determinants of health factors. But yeah, the association there, it's definitely significant.
And I'll just briefly add the comment that, while I think the staging concept is very useful, there are many, many factors, as you know, that go into defining these stages. And even within a stage, you're going to have great heterogeneity and risk, right? So, like with stage 2 and your metabolic risk factors, right? It depends how many of those metabolic risk factors you have and how severe they are, right? So if you're just above the threshold for one metabolic risk factor, your risk is much lower than if you have severe elevations of multiple factors. Same thing with stage 4, right? Or stage 3 with subclinical disease. Really, depends on how severe that is. So there's great heterogeneity within these stages, and I think it's going to be very important for the committee to try to simplify the message to clinicians this about how these are defined and and many of the risk management strategies really are going to apply to all these stages. And I think, it's going to be very important to think about whether some of these newer therapies can prevent even the development of, well, we know they can, right? So even excess adiposity, you're reducing that progression from stage 0 to stage 1 by a GLP-1 receptor agonist. And then, you're also preventing other cardiometabolic risk factors for developing. So you're preventing that transition from stage 1 to stage 2 even, right?
Terrific. Yes, I think that's going to be a very important thing for clinicians who are starting to use the calculator, because once you start doing that, you'll recognize that these are patients who are at higher risk than their individual disease states, and they require higher therapy, which I think should probably translate into more insurance coverage for some of these agents, so that patients who have multiple conditions, multiple comorbidities, perhaps should be more authorized to get some of the newer weight loss agents, etc., for which they could get. So
Yeah, well, there's no longer a shortage of them, and the cost is going down, and they are becoming more available. I understand Costco this negotiated a contract. They're going to offer it, but like at Kaiser Permanente, it's only $30 a month for a lot of people. So so yeah, they are gonna, but we have to, get our patients to understand that, they're not just taking these for weight loss, right? But their biggest risk is really adverse cardiovascular outcomes. And we now have evidence from SELECT and even now some from the recent tirzepatide studies. I showed that you can probably improve cardiovascular outcomes. So there's all this hype about just the weight reduction, right? But patients need to understand that with that, you get dramatic improvements in many of our cardiometabolic risk factors. Blood pressure goes down, lipids improve, and this all translates into improved cardiovascular outcomes. So that message still is not adequately disseminated in the public community.
outstanding.
Oh,
Okay,
Dr.
I think
Sabat.
Beth has a question, so go ahead, Dr. Sabet.
Of course. So first of all, fantastic talk, Dr. Fan, Dr. Wong. Perfect. I really enjoyed it. I learned a lot. So I have two questions actually. Are you guys aware of any data on using SGLT2 on patients with CAD without diabetes? We use it for heart failure, HFpEF, HFrEF, but CAD or ASCVD, I would say, but without diabetes.
That's a
That's
great
a
question.
good
Oh,
question. Yeah.
Dr. Wong, you want to go ahead?
Well, yeah, because we know that infrareg, right, was of course both CVD and diabetes. Yeah, I'm not sure about. So you're talking about yeah. So you're talking about SGLT2s, right? Because
Right.
like GLP-1, of course, we have Select, right? That was
That's right. That's right.
CAD without diabetes, but
That's right.
I'm not aware of uh, a trial using an SGLT2. One thing we do know, of course, from the SGLT2 data is that the composite endpoint was largely driven by heart failure and
Mhm.
cardiovascular death that is mainly from heart
From
failure.
heart failure.
And MI and stroke are, from several of the trials were not significantly reduced.
Nice. Perfect. Thank you. And the second question I have, so we always talk about primary prevention, secondary prevention. I think I want your expert opinion. Patients with coronary artery calcification, let's say calcium score of 100, 70. So do you consider that, so if you treat these patients, you treat them as a primary prevention, or that's already secondary prevention because patient has coronary artery disease?
Yeah, so we know from studies like what Matt Budoff has
Yeah,
done,
300.
right, that cut point was
300.
300 based on
Right.
his study.
But
Okay, but the study that Dr. Malik and I did 10 years ago suggested in diabetes patients that cut point may be 100, where they have a equivalent risk, that 2% per year risk, right, is roughly a CHD risk equivalent. So, in the presence of multiple risk factors or diabetes, right, that cut point may be lower. And there's no well agreed point as to, except probably 300, one would definitely consider that a risk equivalent, um, there's no definite consensus on whether it should be 100. But we know that um, these many people are, that statin treatment, for example, is definitely recommended if you're at least 100. So, and I don't know, maybe Dr. Fan, you have something else to add?
Yeah, I agree. Like from a research perspective, we still see that as a primary prevention because the patients do not have clinical CVD. But as Dr. Wong mentions, if you have a CAG over a certain cutoff points or you have multiple risk factors plus diabetes, you might be CVD equivalent and you might want to intensify the prevention strategy.
Mm. So because I think there is a discrepancy here in a real practice because let's say we cutting as someone, I think Dr. Baker should do it a lot. So if we cutting someone, we see a 50% lesion, we see a 60% lesion, probably the patient, and that's the only lesion, let's say it's a single vessel disease. Probably if you get the calcium score is not going to be that high, but we recommend patients to take aspirin, right? So, but we might see more when we do coronary artery like CAG or CT, we see a lot of like calcification, coronary artery calcification. I think that was actually my question. Yeah, you're right. The 300 Dr. Budov published, and that just, I think maybe I'm wrong, but correct me if I'm wrong. I think the 300 and above, the risk is equal to someone who had ACS before. That's really extreme.
Yeah,
The
yeah,
300 cutoff you're talking
yeah,
about. I think that was really extreme.
yeah,
So, but I don't think he really focused on the people with just, because the stable CAD patients, they need aspirin as well, right? People who never
yeah,
had
yeah, yeah,
ACS.
yeah,
So I think,
yeah,
when we're talking about using aspirin, and not using aspirin in primary prevention is going to make a little bit confusion. That's
yeah,
patients with
yeah.
calcium score of 200.
Yeah. So we know from the Medema study that looked at the benefits of aspirin stratified by coronary calcium scores. We do
Mm-hmm.
know that if your calcium score was greater than 100, then you definitely had benefit from aspirin use because your absolute risk was high enough so that the number needed to treat from aspirin was very favorable. So if you're 100 or higher, the number needed to treat from aspirin is quite favorable. Um,
Perfect.
and and also kind of to support your your suggestion. I think your suggestion may be whether 100 should be like secondary
Exactly.
prevention. So if you look at that stage and paper that I was part of with David Marin, I showed the slide, right? 100 or higher, we want to get that LDL below 70, right? So that's the current recommendation for ASCVD patients. If it was 300 or higher, we want to get it below 55. That's the current recommendation consistent with that very high risk ASCVD patient, right? So
Mhm.
the guidelines define a very high risk patient as someone with 2 or more major events or 1 event and
That's right.
multiple high risk conditions. So they recommend non-statin therapy for LDLs 55 or higher. So that's at 300 or higher. That's the cut point where we kind of equate them to very high risk, as what you just said, and 100 or higher as similar to an ASCVD patient with a LDL target below 70. See?
ELO 70, right, exactly.
Yeah.
Great. It'll be interesting to see how these studies all come together as we're learning more and more about this disease. That cardiac, metabolic, kidney, they're all related. So some of the drugs we use to treat one are going to treat them all. So I think this is great. Is there any other comments that Dr. Wong, Dr. Fan, you would like to say in closing? Okay, well, in that case, I don't think I see any more questions in the chat. Thank you all for coming. We appreciate your coming, and feel free to join us. We have sessions every second Wednesday of the month. The next one in November is going to be Dr. Savet, who'll be talking about inflammation and prevention and coronary and inflammation prevention. So feel free to join us, and thank you for joining, and great presentation from the both. Thank you, Dr. Wong. Thank you, Dr. Fan. And thanks for joining, everyone.
Thank you.
Thank you so much. Thank you, everyone.
Yeah,
Right.
take care.
Talk.
Thank you. Take
Okay.
care. Bye.
Okay. Thank you, Wenja. Okay. And John, thank you. Bye.